Welcome to Complete Anatomy. My name is Dr. Alan Detton, and in this lecture I'll be going over an introduction to anatomical position, planes, and terminology. By the end of this lecture, you will be able to define anatomical position, provide examples of why anatomical position and planes are clinically important, describe the difference between a systemic and regional approach to learning anatomy, correctly describe the orientation of anatomical planes and discuss their significance in diagnostic imaging, and properly use anatomical terminology to discuss relationships within a region of the body or within a system. As we begin our study of human anatomy, it is important to understand that you're essentially now learning a new language. And this language is going to help us better describe how parts of our body relate to one another, or to better help us understand how different structures are named. So some of the different structures within the various systems of the body are going to have names that might at first seem confusing. However, if you understand that these are based on Latin or Greek origins, and you know the name relates to some kind of a descriptive feature, that will help with our comprehension of how these different structures were named and why we call them the things we do. Now, the language of anatomy we often call anatomical terminology. And one of the first concepts we need to understand is that the human body has sort of a default or a resting position that will help us better describe how the various parts or structures relate to one another. The first concept of anatomical position is that the body is standing erect or upright, and this will help us know that we're not sitting down or bent forward as we describe how things relate to one another. We can see that the head is directed towards the front of the body, as are the eyes. So our gaze is directed towards the front and our head is straight forward. The upper limbs are going to be positioned down to the sides of the body in a relaxed orientation. They're not held close up against our side or spread out far apart, and we're not using any energy to keep them upright. The palms of our hands are directed anteriorly, which means to the front, and they're not rotated. So again, we don't have the palm of our hand facing towards our thigh or towards the back of our body. Lastly, the feet are approximately shoulder-width apart with the toes directed to the front. So they're not going to be pigeon-toed, we're not knock-kneed, we're not having our feet splayed out to the sides with too much orientation. So if we understand how the body is positioned in space, it will help us more accurately describe how the different component parts relate to one another. And we'll build on this terminology as we move forward. In order to accurately describe how the different structures in our body are related one to another, we often take advantage of anatomical planes. Now, there are three cardinal or primary planes of our body, and these will be oriented in an X, Y, and Z type of orientation. Now, some of the planes are going to be mobile and be adjustable, whether to the front or back or up or down throughout our body. The first of them, however, is going to only be located in one specific point, and that is the midline. So here, if I were to divide the body into equal right and left halves, I have drawn an approximate location of the median or mid-sagittal plane. So this plane is specifically located right in the middle of our body, and again would subdivide it into equal right and left halves. If I were to adjust that vertically oriented plane and put it in any vertical orientation away from midline, this is simply known as a sagittal plane. And what we see is this divides the body into unequal right and left components. The next type of plane would be located perpendicular to these two vertically oriented planes, and this would be known as an axial plane. Now, an axial plane is going to have multiple names, and this is also known as a transverse or a horizontal plane of our body. And as we can see, it's going to be at a right angle to those vertically oriented median or mid-sagittal planes and any of the sagittal cuts throughout our body. Now, an axial plane could be at any height either above or below this point, so it doesn't have a specific location, but it means that it's in this point of reference, that it's horizontally oriented. So typically, if a physician ordered an MRI, this would be taken in a horizontal or axial plane. Now, the last type of plane that we're going to see will be located at right angles or perpendicular to both of these other types of cuts or slices. And this would be known as a frontal or a coronal plane. And here we have now effectively divided the body into a portion in front of or behind that vertically oriented slice. This is known as anterior or posterior to that point of reference. So the three different cardinal planes, the frontal, median, and axial, are going to subdivide the body into different organizational points of reference. Now this might be used diagnostically or it might be used physically, where potentially a course is focused on looking at cross-sectional slices to better understand the different relationships of the different systems in our body. There are two common ways to teach human anatomy. We can either look at it systemically in a systems-based course or regionally in a regional type of course. In a systems-based course, we would look at how the different component pieces work together to serve a common function. For example, with the skeletal system, we would look at the bones and cartilage and connective tissue that helps to protect and support the different structures in our body. We could also similarly look at the muscular system and see how that interacts with those bones to produce movement. If we were looking at the cardiovascular system, we would be able to follow blood flow from our heart out through the arteries of our body and then return through the veins of our body. So we would look at all of the component pieces as a whole and see how that serves the common function. In a regional approach to human anatomy, we would be looking at how the different systems interplay one with another within that area. For example, here in the head and neck, we would begin components of the respiratory system as well as the digestive system. We could also see inside the skull, if I fade these structures here and turned on the nervous system, we could see the underlying relationships of the brain and cranial nerves with the bones in this area. So the idea with a regional approach is you look at the interplay between all of the different systems within that area of the body. Now, often this is done in a dissection type of course or a more advanced course where you're starting to look at how our body behaves and acts with the different systems one with another. The trunk of the human body can be subdivided into regional spaces, which we are going to refer to as cavities. And there are two major cavities within this region. There's going to be a thoracic cavity located within the thoracic region of our body, and then more inferiorly located, an abdominopelvic cavity. Now, each of these cavities can be further subdivided into different regions within that cavity. For example, within the thoracic cavity, we can further subdivide this into a centrally located mediastinum or a mediastinal cavity and a more laterally located pleural cavity to either side. Within the centrally located mediastinum, we're going to find the heart as the dominant content. However, we're also going to be able to subdivide this into smaller component pieces, which would include structures like the great vessels, the esophagus, and the trachea. So some of the structures that will need to come into the thorax will pass through an area known as the thoracic inlet or aperture. So this is how structures could get from our head and neck or upper limbs in and out of the thoracic cavity. The laterally located pleural cavities are predominantly going to contain the lungs. So our right pleural cavity would have the right lung, while the left would have the left lung. We're also going to have, again, the airways coming in and out for gas exchange and the blood vessels in this region as well. So the dominant feature is the lungs, but we're still going to have some other structures within the pleural cavities. The thoracic cavity is going to be located superior to the abdominal pelvic cavity, and the separation point between these is going to be the diaphragm. Now, in order for structures to pass through the diaphragm, there are specific openings where these structures will pass from the thoracic to the abdominal cavity. The more inferiorly located abdominal pelvic cavity can also be further subdivided into an abdominal cavity, which is more superiorly located, and a pelvic cavity, which would be more inferiorly located. The abdominal cavity is predominantly going to hold the organs of digestion. So here we can see the major digestive organs, but also it's going to contain some of the accessory organs of digestion. The pelvic cavity, on the other hand, is going to contain some of the urogenital structures, like the bladder and some of the internal reproductive organs. So in the male, the prostate gland and seminal vesicles, while in the female, this would be the uterus and the vagina. We're also going to have the distal or terminal ends of the digestive tract located down within the pelvis, so the rectum and the anus. Now, the pelvic cavity is going to be bounded inferiorly by the muscles of the pelvic diaphragm. So you could see that without these muscles, there's just going to be a large opening positioned inferiorly. So these are going to not only help provide resistance, but they're going to help support some of the contents within the pelvic cavity. The superior boundary of the pelvic cavity and what's going to separate it from the abdominal cavity is known as the pelvic brim or the pelvic inlet. And this is a solid ring of skeletal tissue or bones that are going to surround this barrier. So we're going to have a very distinct ring separating the abdominal and pelvic cavities, but it is not going to block off the passage so that the structures from the abdomen can enter or leave the pelvic cavity. Within the major body cavities, we're going to have a special type of lining known as a serous membrane. The serous membrane is going to consist of two different layers, a layer against the wall of the cavity and a layer on the surface of the organ itself. Now, the idea behind having two layers is we want to reduce friction for organs that move a lot. For example, if I were to remove the lungs here in the thoracic cavity and give us a better view of the heart needs to beat all day, every day, and we do not want to have a lot of excessive friction between the heart and the surrounding structures as it beats throughout your life. That would increase wear and tear and likely lead to a lot of damage to the tissue of the heart itself. Now, the idea behind a serous membrane can best be explained perhaps by looking at a simple drawing of a balloon. Here, I've drawn the balloon, which has one layer of thickness surrounding an inner cavity. In this case, the cavity might be filled with air or even potentially water, but it is airtight, meaning that there's not going to be a way for that air or fluid to leave that inner cavity. Let's say hypothetically you were to shove your fist down into that balloon. What you've now done is created two layers out of what was once a single layer. You have a layer tight up against the surface of the fist and an outer layer that is separated from that inner layer by a cavity that could be filled with either air or some form of liquid material. We also have a gap that would allow for passage of structures in and out of that inner aspect. In this case, our wrist, containing the arteries and tendons and structures that are important to make our hand move, can freely come in and out of this gap without penetrating through the actual lining of the balloon, which would cause air or fluid to leak. This is the same concept with our key organs. Now, around the heart and the lungs, we're going to want to have structures pass in and out of that organ, but we want to have an area that would allow for movement in an essentially frictionless environment. You could slightly squeeze and expand your hand, and it would not really affect the outer lining of this structure. Reality is that we're going to have two different layers, so we need to be able to name them depending on their location. The outer layer is known as the parietal layer, and the inner layer that would have surrounded the fist, or in this case one of these organs, is known as the visceral layer, with viscera meaning organ. Each serous membrane is going to have two descriptive terms. The first describes is it on the wall or on the organ itself. The second term is going to tell us of which cavity. So we're going to have a pleural cavity surrounding the lungs, a pericardial cavity surrounding the heart, and a peritoneal cavity surrounding the abdominal organs. By combining these terms, parietal or visceral, with either pleural, pericardial, or peritoneal, we get a distinct description of which layer we're looking at. For example, the parietal pleura is going to be the layer lining the walls of the pleural cavity, whereas the visceral pleura is the layer lining the actual surface of the lung itself. The visceral pericardium is the layer lining the actual surface of the heart, and this would be continuous with the inner aspect of a structure known as the pericardial sac, which is lined by the parietal pericardium layer. Lastly, visceral peritoneum would then line an organ within the abdominal cavity. And we can see by zooming in that there's going to be a thin reflective layer on the surface of the stomach, as well as on the liver, the gallbladder, or the large and small intestine, which are also highly mobile organs within the abdominal cavity. A major component of anatomical terminology are terms of relationship, often described as directional terms. And some of these are going to be found in pairs. Now, the terms could either be used as a pair with one term relating to another, or used independently in some cases. And the idea is that these directional terms or terms of relationship will better help us relate one structure in the body to another. For example, if we were to look at the terms superficial versus deep, we would describe structures that are located closer towards the skin or the surface of our body as being superficial, while those that are directed or further away from the skin are going to be termed deep. So we're going to see that we will have some structures that are going to be more deeply located and some that are more superficially located. A good example of this is the venous system, where we're going to have some veins that are going to be more superficially located and course through the just hypodermis or subcutaneous tissue, while we're also going to have some deep veins that are going to course deeper to other structures. We could also simply describe these structures in relation to one another with these terms. So I could describe the muscles of the arm as being located superficial to the underlying bone. Or I could describe the bone as being deep to the overlying muscles. So the terms are going to be helpful for identification and relationship of one thing to another within the body. Another example of this are the terms anterior or ventral and posterior or dorsal. The anterior or ventral surface of an organ or the body is towards the front, while the posterior or dorsal is towards the back. And you can help remember the term dorsal or back by thinking of the dorsal fin of a dolphin or a fish, which is located along the back of that animal. So the posterior surface or anterior surfaces could also describe an individual organ or a compartment within a region of the body. For example, there are muscles more anteriorly located and those more posteriorly located. We can also describe structures as either being superior or cranial and inferior or caudal. Cranial means the head, while caudal means the tail. So structures that are more superior are closer towards the top of our head, while structures that are more inferior are further away from the top of our head or closer towards the tail, or you could think of it in us as towards the soles of our feet. Now, we could describe the eyes as being superior to the oral cavity, or I could describe the chin as being inferior to the oral cavity. The terms superior and inferior often are going to be applied to the trunk or the structures within the midline of our body, also including the head and the neck. While in the limbs, we might use directional terms of proximal and distal. A proximal structure would be closer towards the point of origin, while distal is further from that point of origin. So we could describe the elbow as being either proximal to the wrist, or the shoulder as being proximal to the elbow. Or we could describe the wrist as being distal to the elbow. We could also use these terms proximal and distal with some of the hollow organs of our body, like those found in our digestive tract, where the stomach would have a proximal end and a distal end, as would the small intestine and the large intestine. So the points being closest to its point of origin would be proximally located, while the distal is further from that point of origin. The last terms I'd like to describe are related to the midline axis, and these are going to be the terms lateral and medial. In anatomical position, I would describe our thumb as being lateral to the little finger or the pinky, which would be more medially located. And this will be helpful as we look at some of the large structures in our body where they may have in their name the terms medial or lateral, again in reference to the mid-sagittal plane in the midline of our body. Another subset of anatomical terms are terms of laterality. Now, terms of laterality are going to be used to describe how an organ or a structure is related either to itself or to other things, but it's used in isolation. And what I mean by this is it's different than the directional terms of relationship we looked at before, which would describe something as being perhaps superficial or deep to another similar structure, or it could be medial versus lateral, or superior and inferior, so terms that come in pairs. If I were to use terms of laterality, they can be used in isolation. For example, if I looked at a muscle in my right thigh, the right rectus femoris, and I described this as a bilateral structure, what that tells me is that there's going to be a mirror image of that structure on the opposite side of the body. So the right rectus femoris is going to be a muscle that helps me flex my hip and extend my right knee. It's going to have the exact same structure on the opposite side of the body with the same name serving the same function. So the left rectus femoris would flex my left hip and extend my left knee. If I were to describe a structure as a unilateral structure, it does not have a pair, meaning it's unpaired and typically found only on one side of the body. A unilateral structure could be like our digestive organs, which would be only found on one side. So my stomach is only going to be by itself. I don't have a right and a left stomach. Similarly, I would have a liver and a gallbladder. These are considered unilateral structures, but they don't have a counterpart on the opposite side of the body. I don't have a right and a left gallbladder, for example. Now, if I were to describe structures as being different structures on opposite sides of the body, I would describe them as being contralateral to one another. For example, my salivary glands, I would have a right parotid gland on my right cheek and under my jaw, a contralaterally located left submandibular gland. Now, just because a structure is contralateral to something else doesn't mean it couldn't also be bilaterally located. So my salivary glands will have a counterpart on the opposite side, so they could be bilateral. However, if I'm describing different structures on opposite sides of the body, I would call them contralateral to one another. If I'm comparing different structures, but on the same side of the body, I would refer to them as being ipsilateral. For example, I might make comparisons to my left hand and my left foot. They are different structures, but they are on the same side of the body, so they would be considered ipsilateral. In more detail, I could describe my left thumb with my left index finger, or my left thumb and my left big toe, and call them ipsilateral to one another. So these terms are going to simply describe relationships, but not be paired like the terms of relationship before. These are now terms of laterality. Hello, welcome to Complete Anatomy. My name is Dr. Alan Detton, and in this lecture I will be going over surface anatomy. By the end of this lecture, you will be able to identify the surface anatomy landmarks on the anterior and posterior aspects of the upper limb. Identify the surface anatomy landmarks on the anterior and posterior aspects of the lower limb. Identify the surface anatomy landmarks of the back, thorax, abdomen, pelvis, head, and neck. And lastly, describe clinical applications for the surface anatomy of each body region. One of the areas where surface anatomy can be quite important is here in the thoracic region. The thorax is going to house and protect the vital organs of the heart and lungs. So it's really important to have a proper understanding of how those structures would present along the surface of the body. A good place to begin the exploration of the thorax is in the midline at a depression known as the jugular notch at the inferior aspect of the neck, or the base of the neck. Now, the jugular notch is going to lie between the sternal ends of the clavicle to either side. Let's begin first by moving laterally along the clavicle, which can readily be felt in most individuals because there's very little superficial fat lying superficial to the clavicle. As you start to move laterally, you're going to reach the lateral aspect, which is the acromial end of the clavicle, which meets up with the acromion process of the scapula here at the acromioclavicular joint near the shoulder. So the clavicle can be a useful landmark for structures within the upper limb as well as within the thorax. If we were to look at a midclavicular line, this is also going to help with orientation down inferiorly in the abdominal cavity. Another useful landmark that can be readily seen is the nipple. And the nipple is going to be at the T4, or our fourth thoracic dermatome region. And that might vary somewhat in individuals, but it's a great visual cue for about the fourth intercostal space. If we move laterally from the nipple, we can see the anterior axillary line or fold here in this thin individual, which is about the inferior aspect of the pectoralis major muscle. Now, if there's an anterior axillary fold, there's going to be a posterior axillary fold. And between those two is a depression in the armpit known as the axillary fossa. And this is a great landmark for physicians to use an approximation of the mid-axillary line for orientation if they need to place a chest tube into those intercostal spaces to drain fluid within the thoracic cavity. And again, if the nipple is approximately at the fourth ribs level, or its intercostal space just below it, then a physician could count 2 more levels below to reach the 5th and the 6th intercostal space, which are common placements for a chest tube. Now, other landmarks are going to lie closer towards the midline. So again, beginning at the clavicle and moving medially, we're going to be able to reach the jugular notch. The jugular notch lies in the midline of the body, which is also referred to as the mid-sternal line, which would divide the sternum equally into right and left halves. Now, inferior to the jugular notch, we're going to feel a transition between the manubrium and the body of the sternum, which is the sternal angle, approximately, in most individuals, at the level of the second costal cartilage. Now, this is another landmark that can be very useful and easily felt to start to count where the ribs are and where the intercostal spaces are. So the sternal angle is far more consistent than the nipple, which can change orientation with the amount of fat in the region. If we move inferiorly from the body of the sternum, we can reach the xiphoid process, which is a small arrow-shaped piece of bone on the inferior extent of the sternum. And the xiphoid process is a good landmark for the inferior aspect of the heart and the superior aspect of the liver, neither of which want to be punctured during chest compressions. So if you were to feel for the xiphoid process, place 2 finger lengths above it, and then perform chest compressions on the body of the sternum, you're less likely to damage or injure the individual you're trying to save. Now, if we move laterally from the xiphoid process, we can move along the costal cartilages and feel the costal margin, which will then help us differentiate the contents within the thoracic from the abdominal cavity. The abdominal cavity can be an interesting area for palpation because it does not have as easily felt of skeletal landmarks like the other regions of the body that we've looked at. Here, we're going to have an anterior wall formed by muscles and soft tissue structures. So we need to rely a lot on visual cues from the thoracic region or inferiorly along the pelvic region to help with orientation of where things would lie in the abdominal cavity. To further complicate things, not everybody is as thin as our model represented here. So there can be a large layer of subcutaneous tissue or fat that is going to accumulate in the abdominal region, often complicating palpation. So let's begin by looking at a couple landmarks that are there for everybody, beginning with the belly button, or the umbilicus, sometimes called the umbilicus. Now, the umbilicus or the umbilicus is going to lie in the midline of the body and can be a great reference tool just for a simple subdivision, and it will lie along the anterior median, otherwise known as the mid-sternal line. So a mid-sagittal cut of the body should bisect the umbilicus. Another point of visual landmarks is going to be halfway along the clavicle, which is the mid-clavicular line. And typically, the mid-clavicular line is going to be along the lateral aspect of the six-pack muscles, our rectus abdominis. And the rectus abdominis will be subdivided by small lines known as tendinous intersections. So in a thin individual, if they flex, you'll be able to actually identify both the midline of the body, the tendinous intersections, and the muscular components of this muscle. And that mid-clavicular line can help you with orientation of structures internally inside the abdominal cavity when it's subdivided into 9 abdominal regions. Now, if we were to continue inferior to the umbilicus, we will see the midline structure of the pubic symphysis, where the right and left sides of the pubic bones come together. And this can also typically be felt in individuals. And there may be varying amounts of fat lying superficial to it, and it may not be the most comfortable for somebody to have palpated. Moving laterally from the pubic symphysis and the pubic tubercles to either side would be the attachment of the inguinal ligament, which separates the abdominal cavity from the thigh. But at the lateral extent of the inguinal ligament, we can palpate the anterior superior iliac spine, part of our hip bone or the ilium. Moving from the ASIS superiorly and laterally, we can feel along our hip bone, which is the iliac crest. And the iliac crest is going to meet up with the mid-axillary line, typically towards the most superior extent of this bone. Now, another couple of landmarks that we saw within the thoracic region can also help us with orientation here in the abdominal cavity. Again, the inferior extent of the sternum at the xiphoid process and the costal margin, which will descend as it moves laterally between the thoracic and abdominal cavities. The back may not be your first area that you think of when you think of clinical procedures or surface palpation to help you identify different landmarks within the body. However, there are a couple of very key procedures and things that are done by a physician that will be performed here in this area of the body. Let's begin by looking at the posterior median or mid-vertebral line. And as its name implies, this is going to lie in the midline of the vertebral column. The bony landmarks that can be felt along the posterior aspect of the back are the spinous processes. And these will be the posteriorly directed pieces of bone that are going to lie superficially. And in a very thin individual, you can actually see a collection of small bumps along the midline. Now, in everybody, you can palpate the vertebra prominens, or I should say in majority of individuals. Now, the vertebra prominens is the spinous process of the 7th cervical vertebra, the most inferior of these bones. So it can be a great landmark that can be used to palpate both cervical or thoracic levels. If we continue to move inferiorly along the median or mid-vertebral line, we can see it's going to create a groove between two large groups of muscles to either side. These groups are known as the erector spinae, and they're important postural muscles in our lower back that are going to extend up through the thoracic region as well. Now, the erector spinae are going to attach inferiorly towards the hip bone, otherwise known as our ilium. And the ilium is going to terminate posteriorly at the posterior superior iliac spine. This is also going to help you identify where we're starting to meet the sacrum, as well as the 4th and the 5th spinous processes of our lumbar vertebrae, which can be a great visual landmark for a physician to be able to see this and then feel it if they're going to be counting up to do a lumbar puncture or an epidural. If they continue to move laterally from the posterior superior iliac spine, or the PSIS, they're going to feel along the iliac crest. And we can see that the iliac crest is actually going to be higher than what we think of as our gluteal region. So if you're looking at the folds within the buttocks, you're going to be a little bit too low if you're looking for where the approximate midpoint of a safe hip injection would be. You want to avoid the large sciatic nerve in that region. Another area that can be useful for a physician is they're going to be listening or auscultating to the lungs posteriorly in a small window between muscles known as the triangle of auscultation. And this is going to be near a few large muscles in the area that will create the borders that are difficult to see. However, we can usually feel or palpate the inferior angle of the scapula, which will lie just lateral to this small triangle. If a patient were to lean forward, they would be able to have this triangular window enlarged, which will ease the ability to listen to the health of the lungs in that individual. Now, moving from the inferior angle superiorly, a physician is going to be able to feel along the medial aspect of the scapula. A more prominent landmark to feel in the scapula is the spine of the scapula. And if you reach your right hand up over your left shoulder and use your fingers, you can feel that spine moving medially, which can also help you find that medial or vertebral border of the scapula. So the scapula is going to have a medial aspect and a lateral aspect that are going to come together at that inferior angle, which again can usually be felt in some individuals. In a clinical scenario, a physician is often going to rely on visual cues or on things that they can easily feel. So this is where the surface anatomy is going to become quite important and relevant to the physician. So they want to be able to either see things or feel them just under the skin. Now, many of these structures are going to be felt under the skin or palpated, while others can simply be viewed. Let's begin looking at the surface landmarks anteriorly in the upper limb with the clavicle. Recall that the clavicle was one of the two bones involved with the shoulder girdle, and it is going to be attaching from the manubrium medially and laterally out towards our scapula. The point of attachment of the clavicle to the scapula is at the acromioclavicular joint. So a physician would be able to palpate along the superior border of the clavicle until it meets up with the acromion process of the scapula, and then palpate the acromioclavicular joint. Typically, a physician could palpate through the large deltoid muscle and feel the greater tubercle of the humerus, located more laterally, a small depression potentially for the intertubercular groove, and a more anteriorly located lesser tubercle of the humerus. Recall that the tendon of the long head of the biceps is going to pass in that intertubercular groove between the lesser tubercle and greater tubercle of the humerus. So this can be a useful area for the physician to be able to palpate regionally and feel those bony landmarks deep to the thick muscle of the deltoid. As we move inferiorly towards the elbow, a physician is really going to be able to palpate quite easily the two epicondyles of the humerus, the lateral epicondyle on the lateral aspect of the elbow and the medial epicondyle on the medial aspect. Recall that the ulnar nerve passed just posterior to the medial epicondyle, and often if a patient hits the medial aspect, they're going to feel a tingling in their palm related to the funny bone, which is the ulnar nerve. So being able to palpate the medial aspect and see the origin of the forearm flexors and the lateral aspect for the forearm extensors can be quite beneficial for a physician. Moving towards the wrist, we're able to almost always palpate the two styloid processes. The styloid process of the radius is going to be positioned on the lateral aspect of the distal radius, and that's going to limit the ability to abduct or laterally deviate our wrist. On the medial aspect of the palm of the hand, we're going to be able to palpate two structures, the pisiform and the hook of the hamate. So two of the carpal bones are readily palpated near the base of the hypothenar eminence within the palm of our hand. Typically, we're also able to palpate the heads of the different metacarpals on the palmar aspect of our hand. And you can also use the proximal and distal ends of the phalanges to palpate through the different joints of the hand. So surface landmarks and surface anatomy are going to be a useful tool for the physician to help diagnose underlying clinical issues. Some of the structures that we were able to palpate and or see along the anterior aspect of the upper limb are also going to be identifiable from a posterior perspective. But we're going to now add to the list a few more structures. The first of these is going to be related to the scapula. The medial border of the scapula can be palpated along the medial edge here of the posterior aspect of the shoulder. Now, the patient might need to roll their shoulder or abduct it slightly or protract it or retract it in order to facilitate a physician being able to properly palpate from the inferior extent of the scapula up along the full length of that medial border. It's quite easy, however, to palpate the spine of the scapula, and you can even do this on yourself by placing the contralateral hand up over the shoulder and walking along the length of the spine of the scapula, which could help you identify the supraspinous and infraspinous fossas. If you continued to palpate laterally along the spine of the scapula, you would reach the acromion process of the scapula, which would then wrap around to form the acromioclavicular joint with the lateral end of the clavicle. At the elbow, we're going to be able to palpate the same two epicondyles of the humerus from a posterior perspective. We're going to be able to feel the medial epicondyle and lateral epicondyles of the humerus. Additionally, you're going to be able to palpate between the two epicondyles the olecranon process of the ulna. Now, the olecranon process of the ulna, if you flex and extend, is going to be able to still be felt in any position of flexion. Palpating down through the forearm, you should be able to feel the posterior border of the ulna, which is going to be quite superficial along the posterior aspect of our forearm. Continuing to feel down the posterior border of the ulna, you will end at the styloid process of the ulna, which is going to be directed more posteriorly than the styloid process of the radius, which will be more laterally located. So remember that the styloid process of the radius limited lateral deviation of our wrist, while the styloid process of the ulna is going to limit extension of the wrist. Typically, in the back of the wrist, you can palpate the capitate, which is going to be the most pronounced carpal bone that you will feel, especially in a flexed wrist along the midline. The metacarpal bones can similarly still be palpated on the dorsal aspect, and actually the heads of the metacarpals are going to be relatively easy to palpate in anybody as they flex or make a fist, as are the different interphalangeal joints and the phalanges involved in the fingers. In order to perform a productive or effective evaluation of a patient, the physician will often need to rely on visual cues or things that they can feel underneath the skin within a patient. Therefore, a proper understanding of the structures that are in the surface of the skin, that we refer to as surface anatomy, is an essential foundational set of knowledge that a physician must rely on. Let's begin with looking at some of the surface anatomy that can be palpated or felt within the inguinal region. First, a physician can almost always palpate or feel the iliac crest, the large prominence of bone on the lateral aspect of our hip that we can better see on the side of the body here that does not have the skin. If a physician were to follow the iliac crest anteriorly, they will arise at the point known as the anterior superior iliac spine, or the ASIS for short. This is going to be the lateral attachment of the inguinal ligament, which is going to pass inferomedially along the crease between the abdomen and the thigh, to the point where it attaches medially at the pubic tubercle. Typically, in most patients, the pubic tubercle and the ASIS can be readily palpated. In a very thin individual, a physician might even be able to palpate the pubic symphysis in the midline. On the thigh, we're going to be able to palpate certain structures in thinner individuals more readily than larger individuals, such as the greater trochanter, the large prominence that is for gluteal muscle attachment on the lateral aspect of the hip. At the knee, a physician can palpate the distal aspect of the femur with the lateral epicondyle and medial epicondyle of the femur readily palpated on the lateral aspect and medial aspects of the knee to either side of the centrally located patella, which is perhaps the most readily identifiable surface anatomy within the body. Inferior to the patella to either side, a physician can palpate both the lateral and medial condyles of the tibia, just distal to where the patella is going to slide over the proximal end of the tibia. Near this location, a physician can also palpate on the lateral aspect of the knee, the head of the fibula, which is going to be an attachment site for the fibularis longus and brevis, just inferior to the knee joint. They can also palpate Gerdy's tubercle, typically along the lateral aspect of the knee as well as the tibial tuberosity. The tibial tuberosity is going to be the distal attachment of the patellar tendon or ligament that is going to attach from the patella down to the tibia. Inferiorly, at the ankle, along the lateral aspect of the ankle, a physician can easily palpate the lateral malleolus, which is the distal end of the fibula, as well as the medial malleolus, which is the distal end of the tibia. Typically, the tibial crest, or the anterior aspect of our shin, can readily be palpated, which will then lead inferiorly to the medial malleolus. Lastly, within the foot, a physician can palpate the different metatarsal bones that are going to be within the central aspect of our foot, as well as the different phalanges in the toes. Some of the structures that were able to be palpated or felt along the anterior aspect of the lower limb can also be palpated along the posterior aspect, as these structures are going to either be along the lateral or medial aspects of the limb. Let's begin looking at some of the structures that can be palpated or felt within the skin of the lower limb posteriorly near the gluteal region, beginning with the iliac crest and the posterior superior iliac spine. As we can see, the iliac crest on the left side here without skin is going to terminate posteriorly at the posterior superior iliac spine, often abbreviated simply as PSIS, and this can be an excellent landmark within the gluteal region. They can also palpate the gluteal fold, which is going to be the fat-filled crease along the inferior aspect of the buttock. On the lateral aspect of the hip, the greater trochanter is a good landmark that will help a physician identify the approximate path from the PSIS to the greater trochanter for the location of the piriformis, which can help them identify the approximate path of the sciatic nerve. At the knee, a physician will be able to palpate both the lateral epicondyle of the femur and the medial epicondyle of the femur from both a posterior and anterior perspective. Along the lateral aspect of the leg, just inferior to the knee, they can also palpate the head of the fibula, posteriorly and slightly laterally here at the back of the knee. Near the ankle, a physician will be able to palpate both the medial and lateral malleoli, which are going to be the inferior or distal extents of the tibia along the medial aspect and the fibula along the lateral aspect. Additionally, at the heel, they will be able to palpate or feel the calcaneal tuberosity, which is the inferior or distal attachment of the calcaneal tendon, which is the large tendon attachment of the gastrocnemius and the soleus. The anatomy of the face and the head can readily be felt or palpated in the majority of individuals due to the thin layer of subcutaneous or connective tissue. Now, as a landmark, let's begin along the jawline, otherwise known as the body of the mandible. In the body of the mandible is this horizontally oriented portion of the bone, where if you were tired and rested your chin on your hand, you would likely be resting it on the body of the mandible. The body is going to change directions at the ramus, or to the ramus at the angle of the mandible. So if you were to move posteriorly along the body, it's going to change directions and the bone will start to ascend vertically. And this is the angle of the mandible. Now the ramus is going to continue superiorly, and if you were to continue to palpate up the side of the face, you would actually start to reach towards the zygomatic arch, which is part of the zygomatic bone or your cheekbone. Now, moving posteriorly on either side from the mandible superiorly, you start to get after the angle towards the ear. Now, the anatomy of the ear is going to vary in some individuals where they may have an attached earlobe or not, and that portion of the ear is known as the lobule. It's a fleshy, large portion inferiorly that is often pierced. The large outer circumference of the ear is known as the helix. We also have a small prominence that is going to project from the anterior aspect moving posteriorly, covering up over the opening, the external acoustic meatus. And this small piece of tissue is known as the tragus. Posterior to the ear, we're also going to have a large bump, which is the mastoid process. And this is going to be one of the attachment sites of the muscle in our neck, the sternocleidomastoid. Again, readily felt posterior to the ear, and this is part of the temporal bone. Moving towards the back of the head, there's often a bump that can be felt right in the midline towards the base of your skull. This is the external occipital protuberance, and it's part of the occipital bone. So these are landmarks that can easily be felt in an individual. We're also going to have some landmarks that are simply seen visually, but could also be touched or felt, including around the circumference of the oral cavity, where we can see a change in color from the fleshy pink type of appearance of our lips towards the rest of our skin of our face. And this is known as the vermilion border, and it may be more or less pronounced in different individuals. Superiorly to the upper lip, we're going to have a small depression or indentation in line with the nose, and this is the philtrum. The philtrum is going to lie in the midline to either side of the openings to our nasal cavity, the external nares, otherwise known as the nostrils. Moving superiorly, along the bridge of our nose, we can feel the nasal bones. From here, if a physician were to palpate laterally, they'd be moving along a bony prominence known as the superciliary arch, or the brow. And in many individuals, there's a small indentation known as the supraorbital notch, which is where we're going to have neurovascular structures from the orbit reach the forehead. The surface anatomy of the neck is fairly straightforward in that most of the structures that can easily be palpated or felt lie approximately in the midline. One exception is a large muscle that cuts diagonally across the neck, the sternocleidomastoid muscle. And this is a great landmark muscle for physicians who may be trying to feel enlarged lymph nodes along this diagonally oriented muscle, or looking potentially for a pulse in the carotid vessels just deep to this muscle. Now, the sternocleidomastoid is named due to its sites of muscular attachment. Inferiorly, it is going to attach to both the sternum and the clavicle, particularly the sternal end of the clavicle, which is towards the midline of the body. Between the two sternal ends, there's a small depression known as the jugular notch, which is just superior to the manubrium of the sternum. So if we begin by palpating the bony skeletal landmarks of the manubrium and the medial or sternal end of the clavicle, you can start to ascend diagonally up through the neck along the sternocleidomastoid muscle. Now superiorly, the other portion of this muscle gets its name due to the large bony prominence posterior to our ear of the temporal bone, known as the mastoid process. So sternocleido gets its name from sternum and clavicle, and mastoid from the mastoid process. Along the midline of the neck itself, we're now going to use a landmark that is more prominent in males than females, and this is the laryngeal prominence, otherwise known as the Adam's apple. And we can more readily see this if I fade a portion of the skin on the right side of the neck. Now here we can see the extension of the cartilaginous tissue right in the midline of the neck. This is the thyroid cartilage. And with puberty, a secondary sex characteristic of males is that this starts to become more elongated and pronounced and project more anteriorly, which will help to deepen the voice and the vocal cords get longer. Now, the laryngeal prominence is a midline structure that can be used as a landmark. If we move superiorly towards the angle between the jaw and the neck, you can often palpate the mobile hyoid bone just deep to the skin. Inferior to the laryngeal prominence, we can palpate the next piece of cartilage, which is the cricoid cartilage. And between the cricoid, the more inferior piece of cartilage, and the thyroid cartilage, we have the cricothyroid ligament. And this is an excellent point for an emergency individual responder to be able to do a tracheotomy in an emergency situation where they may need to open up the airway. And this is a safe place to perform this procedure, where they will be able to palpate with their thumb or a finger the laryngeal prominence, move inferiorly, and fill a small gap between the cricoid and thyroid cartilages. And here is where they would insert a knife or a small scalpel to be able to open up the airway to ensure that the individual can breathe and get air into their lungs.
In this lecture, we will review some basic surface anatomy features that are easily palpable on yourself or on a patient. Let's begin in the midline at the pubic symphysis. The pubic symphysis is in the exact midline of the pelvis, and just lateral to it is a bony prominence known as the pubic tubercle. The pubic tubercle is important for the reason that the inguinal ligament attaches to it in the midline. If we palpate and follow the inguinal ligament laterally and superiorly, you can feel the prominent bony feature at the front of your hips known as the ASIS, or the anterior superior iliac spine. So between the ASIS and the pubic tubercle runs the inguinal ligament. Now if we move down in towards the external genitalia on the penis, it is subdivided into the body or shaft of the penis, and if the individual is uncircumcised, they will have a longer and more noticeable foreskin, and on the distal end of the penis is the external urethral orifice. Posterior to the penis is the scrotum for palpations to check for things like testicular cancer.
Hello, my name is Dr. Alan Detton, and in this lecture I will be going over the muscles of the upper limb. By the end of this lecture, you should be able to identify and describe the actions of the extrinsic muscles of the upper limb. Identify the muscles of the rotator cuff and describe the joint action of these muscles. Identify the muscles within the anterior and posterior compartments of the arm and describe the actions of each. Identify the muscles within the anterior and posterior compartments of the forearm and describe the collective actions of each group. And lastly, identify the major structures within the hand. Before we start taking a closer look at the actual names of muscles within the upper limb, I want to first introduce the concept of how the muscles are organized within this region of the body. Now, the first thing to notice is some of the muscles are going to be found within the upper limb itself, and these are going to be considered intrinsic, meaning that they start and stop within that region of the body. Another group is still going to affect movement of the upper limb, but they will begin outside of this area, and then they're going to insert or end within this region of the body. And these are known as extrinsic muscles of the upper limb. So some of the large dynamic movers of this region or appendage are going to be considered extrinsic muscles. Some of these in particular are going to originate from the scapula, or the bone of our shoulder, and insert in the humerus, or the bone of the arm. And these are considered scapulohumeral muscles, and we'll take a closer look at them as well. The muscles of the arm itself are going to be divided into two categories, those that are going to be in front of the bone and those behind, otherwise known as anterior compartment muscles and posterior compartment muscles. Similarly, the muscles of the forearm are going to be divided based on their orientation with the two bones in the forearm, the radius and the ulna. Therefore, similarly, we're going to have a group of muscles in front of or behind, known as anterior and posterior compartment muscles respectively. The last muscles we're going to take a look at are going to be the muscles in the hand itself, which will be subdivided based on if they affect movement of the thumb or the little finger, or collectively affecting the different digits within the hand. The extrinsic muscles of the upper limb can be subdivided into three different groups based on their orientation or sites of muscular attachment. The first of these are the anterior axio-appendicular muscles, and as their name would imply, they are going to be attached more anteriorly on the thoracic wall, and they will begin at the axial skeleton but insert on the appendicular skeleton. Their counterparts are the posterior axio-appendicular muscles. Now the third group is going to be the scapulohumeral muscles, which as their name implies would begin on the scapula and end on the humerus. Let's now take a closer look at these three groups of muscles individually. The first group, the anterior axio-appendicular muscles, is a group of 4 different muscles. The largest and most superficial and prominent of these is the pectoralis major. Now the pectoralis major is a large dynamic mover of the upper limb that begins on the sternum and the clavicle as well as the costal cartilages, and it's going to insert on the humerus. If we hide the pectoralis major, we can see the other 3 muscles more clearly, including the pectoralis minor, which is going to be positioned deep to pectoralis major and attach from our 2nd, 3rd, and 4th, or in some cases the 5th ribs, up to the coracoid process of the scapula. Inferior to the clavicle, we see the small subclavius muscle. This small muscle is going to assist in pulling down our shoulder by pulling down on the clavicle. Now the 4th of these muscles is the serratus anterior. This large muscle is going to attach in a serrated or jagged appearance to our ribs after originating from the medial aspect of our scapula. So the serratus anterior is going to be in this anterior axio-appendicular group due to its anterior attachments along the ribs. The next group of muscles are the posterior axio-appendicular muscles. And here we're going to see 2 large muscles more superficially oriented and 3 muscles more deeply located. The first of these is a large diamond-shaped muscle in our back that is positioned more superiorly. And this muscle is the diamond-shaped trapezius or square-shaped trapezoidal-shaped muscle. Inferior or deep to this muscle, we see the large, broad, flat muscle of the latissimus dorsi. So these first 2 muscles are more superficially located, and they're going to take up a lot of room and create large dynamic movements similar to what we saw with pectoralis major anteriorly. Now, deep to the trapezius, if we were to hide this muscle, which we have done on the left side of this specimen, we can see the 3 underlying deep muscles. Beginning superiorly, with the levator scapulae, the intermediate muscle, the rhomboid minor, and the most inferiorly, the rhomboid major. Now the rhomboid major is going to be positioned most inferior, and it's going to be a rhombus in shape, as is the rhomboid minor. The rhomboid minor we can identify due to its close proximity to the spine of the scapula, while the rhomboid major is positioned inferior to it along the medial border of the scapula, and lastly the levator scapulae positioned superior to that spine of the scapula. The last of the three groups we're going to take a closer look at in more detail, and this is going to be the scapulohumeral muscles. Now, the scapulohumeral muscles are going to be attaching, as their name implies, from the scapula and attaching on the humerus. These are going to include the large deltoid muscle, which is triangular in shape on our lateral aspect of our shoulder, the teres major muscle, which will be positioned inferior to the teres minor muscle. Now, the other four muscles in this group are going to form part of a group of muscles known as the rotator cuff, and we'll take a closer look at them in more detail in a moment. There are four muscles that comprise the group we commonly refer to as the rotator cuff. Now, the rotator cuff serve together to form a common action. These four muscles will contract to create tension here at the shoulder joint, which provides stability. By hiding the connective tissue, we can see the underlying head of the humerus, which will be better kept intact with the glenoid fossa of the scapula as these muscles contract as a unit. Now, individually, the four muscles are going to have independent functions, or they'll work with other groups of muscles to perform an action. However, collectively, know that the rotator cuff serve to provide shoulder stability by keeping the head of the humerus tight against the glenoid fossa. To help you remember the four muscles of the rotator cuff, I like the mnemonic SITS, S-I-T-S, which helps you remember the first letter of each of the muscle names. For orientation, begin by identifying the spine of the scapula on the posterior aspect of this bone. Then progress superiorly to identify the supraspinatus muscle. The supraspinatus muscle is going to act to help raise our shoulder in the motion known as shoulder abduction. Now, other large muscles are going to contribute to this dynamic movement. However, the first 15 degrees of motion are going to be provided by the supraspinatus muscle. So the supraspinatus will begin to contract, the upper limb starts to move away from the body, and now it's at a point for muscular advantage of the other muscles to kick in and help to continue the motion of raising our shoulder. The infraspinatus muscle is going to be located inferior to the spine and, combined with the teres minor, assist in the action of lateral rotation of the upper limb, or in particular of our humerus. So here we can see the teres minor and the subscapularis both contracting along with the deltoid to produce lateral rotation of our upper limb. The last of the four rotator cuffs is located anteriorly, and the subscapularis is therefore going to produce a counter movement to the infraspinatus and teres minor. And this is going to be medial rotation of the upper limb. Now, medial rotation is a much stronger, more dynamic movement due to the presence of the other large muscles in the region which assist with this action, including teres major, latissimus dorsi, the deltoid, and pectoralis major. By fading these large muscles, we can see when subscapularis is activated to assist in medially rotating the upper limb. Now, commonly we hear about the rotator cuff when it comes to an injury, and the most commonly injured of these four muscles is the supraspinatus muscle. So, the shoulder is going to become aggravated and cause pain when we abduct the upper limb, As this muscle contracts, it is going to cause a pinching or a tightening sometimes within this region superior to the supraspinatus as it passes deep to the acromion process of the scapula. So, although the most commonly injured of these is the supraspinatus, this is going to lead to shoulder instability as a group because they can no longer as effectively keep the shoulder stable up against the scapula. Before taking a closer look at the actual muscles within the arm, I want to discuss the idea of compartments. Before we do so, recall that the arm is the region of the upper limb located between the shoulder and the elbow, while the forearm is the region between the elbow and the wrist. So if I'm describing muscles of the arm, be sure that you're thinking of this region between the shoulder and the elbow. Within the arm, we're going to divide this up into two different compartments. We're going to see that there's an anterior compartment of the arm, which will be located in front of or anterior to the humerus, and a posterior compartment of the arm, which will be located posterior to or behind the humerus. Now, it's often easiest to understand how these structures are organized by taking a closer look at the arm with a cross-sectional view in mind. So what we're going to do is take a look at a cut through the entire arm at the same time and discuss some of these structures in more detail. Typically, when we look at a cross-sectional cut of a region, we'll be looking at it from an inferior to superior perspective, because this is how diagnostic imaging is done. You would be standing near the patient's feet and looking towards the patient's head. So it's a good orientation to be familiar with of looking from an inferior to a superior perspective. The first thing to look at with the cross-sectional cut of the arm is that this is essentially a round structure. So that will be an indication that we're looking at a cross-sectional cut somewhere in one of the limbs. Now, the next thing to identify is if there's one bone or two bones within this region. In this case, we have one centrally located bone, which is going to be the humerus. Anterior to the humerus, we are going to have the anterior compartment of the arm, with three different muscles shown here in cross-sectional cut. We're going to go into more detail about what these muscles are, but for now, realize there's going to be a subdivision between the group of muscles located in front of or anterior to the humerus and those located posterior to it. The posterior compartment of the arm has been highlighted in pink. And although this looks like there's multiple components, which there are, they're actually all of one large muscle, which we'll look at in more detail with the posterior compartment of the arm. What I wanted to highlight here in this cross-sectional cut is not only the fact that they're going to be located in front of or behind the humerus, but that there's going to be additional structures within these compartments. So it's not just muscles in isolation. For example, within the anterior compartment of the arm, we're going to need a nerve to make those muscles move, which is going to be the musculocutaneous nerve. And we can see that it is sandwiched within the different muscles within this compartment. Similarly, near the posterior compartment of the arm, we're going to see a nerve known as the radial nerve, which is responsible for providing motor innervation to the muscles within this posterior compartment. Now, beyond the arm or distal to it, we're going to need more nerves to reach the forearm or the hand. And that's where we're going to see medially here with the median nerve and the ulnar nerve. So although they don't reach target structures within the arm, they need to continue to the forearm. So they will pass through the arm to get to those targets. Additionally, after nerves, we're going to see the presence of blood vessels. We can see on the medial aspect of the arm a large artery. This is known as the brachial artery. Recall that the brachium is another name for arm. So the brachial artery will be the key artery within the arm. We're going to have some deep veins located near that brachial artery, and a couple of superficial veins also traversing through the region of the arm, namely the basilic vein and the cephalic vein. So I would strongly recommend, after looking or listening to some of these other recordings and lectures on the components of the arm, to come back and revisit this one to better understand the different compartments and structures within a cross-sectional view. There are 3 muscles in the anterior compartment of the arm. And if you remember that the arm is also known as the brachium, the names will make a lot more sense. As we see, all of these muscle names have brachii in the name, which helps you remember that they belong to the arm. The first of these muscles is located most superficially, and it has 2 components, a more laterally located long head and a more medially located short head. Biceps actually means 2 heads or 2 bellies. So this muscle, the biceps brachii, is a 2-headed muscle of the arm. The long and the short refer to the length of the tendon. So as we come more superiorly here and we look at the shoulder, we can see that one of these tendons has a much longer route than the other. The long head of the biceps is a much longer tendon than the short head of the biceps, and that's where their names come from. The second muscle that we're going to see here in the anterior compartment of the arm shares an attachment with the short head of the biceps. This muscle is the coracobrachialis. Now, the coracobrachialis, as its name implies, will attach from the coracoid process of the scapula to the arm, or the brachium. And we can see here that this muscle is tucked underneath or deep to the short head of the biceps brachii. The last of these 3 muscles is the brachialis muscle, or the muscle of the arm. Now, the brachialis muscle only crosses the elbow, and it's going to attach to the ulna, unlike the biceps, which attached to the radius. As we look at the actions of these muscles and you think about which joints they cross, those are the joints that will have movement associated with muscular contraction. If I select the biceps brachii and we look at the motions of this muscle, you can see that it's going to assist in elbow flexion as it passes the elbow joint. It's also going to assist in shoulder flexion as components of this muscle cross the shoulder as well. Now, if we look at other actions provided by the biceps brachii muscle, we can see that it's also going to produce another action in the forearm, and this is supination. So as the muscle contracts, it's going to straighten our wrist back out after you pronate it. So pronation will tilt the hand to face posteriorly or in the back of the body, while supinating is going to return it back to anatomical position. If you remember these actions and you think about going to the gym and you want to lift weights and strengthen the anterior compartment of your arm by doing forearm curls, what you're going to see is that you can lift more weight in a fully supinated position than you can in a pronated position. The reason for this is once we have supinated, the biceps can now focus on flexion of the elbow. But while it is pronated, it is going to spend its energy trying to twist that forearm back into anatomical position. So the dominant elbow flexor, whether we're in pronation or supination, is actually the brachialis muscle. Now, the biceps typically gets the credit, and that's the one that we see more superficially and it's more pronounced. But just remember that these muscles are all going to be named based on their location, their orientation or sites of muscle attachment, and their actions are going to be related to the joints that they cross. The posterior compartment of the arm consists of one large dominant muscle, the triceps brachii. Now, as its name implies, this is a 3-headed muscle of the arm. The long head of the triceps brachii is going to cross both the elbow with the other 2 heads and the shoulder by itself. This is the only one of these three heads that crosses both joints. And as we can see, the long head is going to split in between the teres minor and teres major muscles near our shoulder. The long head is situated most superficially of these three components of the triceps, and the most posteriorly. On the medial aspect, we're going to see the medial head of the triceps brachii. And if I fade the long head, you'll be able to see that the medial head passes deep to a large portion of the long head, and it's going to be positioned side by side with the third belly, or the lateral head of the triceps brachii. So the medial and lateral heads will be positioned side by side against one another along the humerus, and the long head will be positioned more superficially. The other muscles in this region are going to originate in the posterior compartment, but also cross the elbow, and that is the brachioradialis and the anconeus, which we will see later on in the forearm. Before taking a closer look at all of the muscles within the forearm, I want to go over the idea of compartments within this region. So recall that the arm was the area between the shoulder and the elbow, while the forearm is going to be the area between the elbow and the wrist. And there's going to be a lot of small muscles within this region that are going to help perform all of the small, fine movements within our hand and our wrist. These muscles are going to be grouped into two different compartments. An anterior compartment of the forearm, which will be located more anteriorly and medially, and found anterior to or in front of the two bones within the forearm, the radius and the ulna, while the posterior compartment of the forearm is going to be more posteriorly and laterally located, and it will again be located posterior to or behind the bones within the forearm, the radius and the ulna. To better understand the compartments of the forearm, let's take a closer look at a cross-sectional cut through this region of the upper limb. Recall that within cross-sectional views for diagnostic imaging, we will be looking from the feet of the patient back up towards the head, so from an inferior to a superior perspective. The first thing to notice within this cross-sectional cut is again the round appearance of the entire region. Next, we would look for the location of the bones, beginning with the two deeply located bones, the more laterally located radius and the more medially located ulna. Now, depending on where we are within the forearm, which one is closer to the surface or their orientation relative to the muscles within the anterior and posterior compartments might vary a little bit. However, we're still going to see two bones throughout the entire length of this cross-sectional cut. Connecting the more laterally located radius and the more medially located ulna, we're going to have a strong connection of fibrous tissue, known as the interosseous membrane, and this will help further subdivide these two compartments of the forearm. In blue, I've drawn the more anteriorly and medially located anterior compartment, which is going to contain the flexors of our wrist and hand. While in green, I've drawn the posterior compartment muscles, which are going to be extensors of the wrist and hand and located posteriorly and laterally within the forearm. Similar to the arm, we're going to have different structures besides just the muscles that we can see within each of these compartments. We'll begin by taking a closer look at the nerves. Recall that there's going to be nerves passing from the arm into the forearm, two of which are going to be responsible for providing motor innervation to the anterior compartment muscles. These are going to be the median nerve, which is closer to the midline of the forearm, and the more medially located ulnar nerve. Within the posterior compartment, we're going to have branches of the radial nerve. And here we can see one of the superficial branches traveling along the lateral aspect of the forearm. We're also going to see within this cross-sectional cut some of the vasculature. We can see a more laterally located radial artery and a more medially located ulnar artery. So the names of these vessels will correlate to the bone that they are closer to. We're also going to have deep veins next to those arteries and the superficial veins coursing within the subcutaneous tissue, namely the cephalic vein more laterally and the basilic vein more medially. So similar to the compartments of the arm, I recommend that you look at the compartments of the forearm after having seen the muscles and other neurovascular structures within this area in more detail. The muscles in the forearm can be quite complex and intimidating when first looked at. There are a lot of muscles in this region, and some of them have very long names that might be intimidating at first. However, if we look at how these muscles are organized and how their names make sense, we can break it down more methodically and really start to understand how this region of our body is organized and how the muscles are named. The first thing that I do as I look at the forearm muscles is identify the brachioradialis muscle. Now, the brachioradialis originates in the posterior compartment of the arm, but it crosses anterior to the elbow to insert at the styloid process, and this muscle produces elbow flexion, especially in a mid-pronated position. Now, by identifying the brachioradialis first, we can start to split the forearm into two different groups. A group of muscles that originates on the medial side from the medial epicondyle at our elbow, and we see its tendons passing anteriorly down into the palm of the hand. As a group, these muscles produce flexion of the wrist or of the digits. So we often refer to this compartment as the flexor compartment of the forearm. Now, the flexors are going to be arranged in different layers. The other group of muscles, after identifying brachioradialis, are going to be found on the lateral aspect of the forearm, and these are going to be known as the extensors. So they will arise from the lateral epicondyle, or the lateral side of our elbow, and aim more towards the dorsum of the hand. And as these muscles contract, the tendons are going to produce extension of the wrist or of our digits. So the first thing to look for is brachioradialis, and then we identify, are they more anteriorly located going to the palm, or are they more posteriorly located going to the dorsum of the hand, which will tell us if they are flexors or extensors. The next thing we want to do is look at, are these tendons going to be on the outsides or the insides of the wrist? Now, if they're going to be on the outside, they often have carpi in the name, or they're going to be going to a digit in the midline. So here we can see that some of these are going to be coming towards the wrist, and their name will have carpi in the name. If they go to a digit, they're going to have digit of some form in their name, or they may go to the thumb and have pollex in their name. So as you look at the target of each of these tendons, it will help you identify what is the name of that structure. Next, what we want to do is verify if these tendons are going to be on the radial side or the ulnar side of our forearm. So we've evaluated what is their target. Does it go to the wrist, to a digit, or to the thumb? And now we're evaluating, is it on the radial or lateral aspect of our forearm, or the ulnar or medial side? Now, as the forearm can rotate, you may want to use a reference like the thumb to help you identify if this is the radial side of the forearm, and the pinky to help you identify if this is the ulnar side of the forearm. The last thing that we want to check is, does it have a long or a short tendon? And this will help you with the last of the names, which is brevis or longus. Now, a longus tendon is going to have a longer route or a longer length of tendon than would a brevis. So brevis means short, longus means long. And that will be again related to the length of the tendon. So before worrying about the actual individual names, break it down and look for, is this on the anterior side as a flexor? What is it affecting? And does it have a long or a short tendon? The anterior compartment of the forearm consists of 3 different layers of muscles. But before we start looking at the different muscles and all of their names, let's recall the strategy for how they are named. The first term is going to tell you what the action is. So it's going to differentiate as a flexor versus an extensor in many cases. The second term, if it has 3 names, is going to tell you the target structure, whether that's the wrist or the digits, while the last name will be a descriptor of some sort. Let's now take a closer look at the first or the superficial layer of the forearm flexors and follow this naming protocol. The first of these muscles is named the pronator teres, and as we would expect, the first word is the action and the last word is a descriptor. So this is going to produce pronation of our forearm by a round muscle, teres meaning round in Latin. We can see that this will be assisted by another square-shaped muscle that is the pronator quadratus, or the pronating muscle that is square-shaped. Next to the pronator teres, we see that the flexor carpi radialis is going to begin near the medial epicondyle of our humerus, cross the wrist, but it'll be positioned on the radial side. So this is a flexor of our wrist on the radial side. The next muscle that we see is the palmaris longus, and the palmaris longus is going to be a long, thin, tendoned muscle that crosses superficial to the flexor retinaculum. So this is the only tendon in our wrist that crosses superficial to this thick band of connective tissue, and that will help you identify this muscle if present. Not everybody actually has a palmaris longus muscle. The fourth of the superficial flexors is the flexor carpi ulnaris, or the flexor of the wrist on the ulnar side. And we can see that this is the largest of the 4 superficial flexors, and it's also going to assist in medial deviation of our wrist. Now the 4 superficial flexors are located superficial to the intermediate or second layer, which actually only has 1 muscle in this layer. And don't be fooled by the name, the flexor digitorum superficialis. This tells us that this is a superficial muscle when compared to its counterpart, the deep, but it is not part of the superficial compartment muscles. The name of this muscle is the flexor digitorum. Therefore, it flexes the digits, but it is more superficially located. The third layer, or third set of muscles in the forearm, are the deep group or deep layer muscles, and there are going to be 3 muscles found in this most deep layer. The flexor digitorum profundus is the counterpart I spoke of a moment ago. So this will be the flexor of the digits that's more deeply located. And as we can see, the flexor digitorum profundus, as was the case with the superficialis, splits and sends a tendon to each of our 4 digits, excluding the thumb, which is not considered a digit. This muscle, the flexor pollicis longus, takes care of the thumb for us, and as its name would imply, it flexes the thumb but with a long tendon. What we'll see is there's a counterpart, a flexor pollicis brevis, located in the hand itself. The third muscle in this third layer is the pronator quadratus, which is the square-shaped pronating muscle we first saw assisting the pronator teres. So as you look at the muscles here in the anterior compartment of the arm, recall their action, then their target, and lastly, a descriptive term. Unlike the anterior compartment of the forearm muscles, the posterior compartment of the forearm muscles really are all found more or less in 1 layer. Now, these muscles are going to start with the same key identifier as we did with the anterior compartment, which is the brachioradialis. So this landmark muscle will identify if we are going to be on the anterior or the flexor side of the forearm or the posterior or extensor side of the forearm. Now, once you've properly identified the brachioradialis, we're going to follow a similar naming protocol that we did with the anterior compartment muscles. meaning that these muscles are going to be named first with an action descriptor, and then they'll tell us what target structure, and lastly have a descriptive term. So we're going to see that as we begin with the brachioradialis as our landmark muscle, we can then start to progress down the lateral side or the radial side of the forearm with an accurate description of these muscles. The first name tells us the action, so these will be the extensor muscles of the wrist on the radial side with either a long or a short tendon. So the extensor carpi radialis longus muscle has a long name. However, it's a very descriptive name that will tell you exactly where it goes and what it does. So this is an extensor of the wrist on the radial side with a long tendon. Located immediately deep to this muscle, we see the extensor carpi radialis brevis muscle. Now, the extensor carpi radialis brevis muscle is going to be located deeply to the extensor carpi radialis longus muscle. The length of the tendon is going to differ. So the longus will have a longer tendon and the brevis will have a shorter tendon. The abductor pollicis longus is sort of an exception in this region. However, it's going to have a similar naming protocol. It abducts or abducts the thumb, its target, the pollex, with a long tendon. And the reason I call it an oddball is it's one of the few that does not have extensor in the name in this posterior compartment. So the abductor pollicis longus muscle is going to cross superficial to the tendons of extensor carpi radialis brevis and longus. As we continue moving down the forearm, we're going to encounter two muscles that extend the thumb, one with a short tendon and one with a long tendon. So here we see that we have the extensor pollicis brevis next to the extensor pollicis longus. Now, interestingly enough, once you have identified the brachioradialis muscle, these muscle names are all going to alternate with their last term being longus, then brevis, back to longus, to brevis, back to longus. So every other term switches. So we have extensor carpi radialis longus, then extensor carpi radialis brevis. The abductor pollicis longus is going to be in between the two extensors of the wrist and our two extensors of the thumb, the extensor pollicis brevis and extensor pollicis longus. Now we see that all of these tendons are going to pass deep to the extensor retinaculum, and all of those 5 muscles are on the radial or thumb side of our forearm. In the middle of the posterior forearm, we see the extensor digitorum. Now note that there is no longus or brevis or superficialis and profundus with this muscle. It is simply known as the extensor digitorum. So extensor of the digits. Now on the most medial side or ulnar side, we see the extensor carpi ulnaris. And as its name would imply, this is going to be the extensor of the wrist on the ulnar side. And compare that, there's only one extensor carpi ulnaris, while we had 2 extensor carpi radialis longus and extensor carpi radialis brevis on the radial side. The last 2 muscles only go to one target finger, the extensor digiti minimi and the extensor indicis. So there's a tendon located deep here to the extensor digitorum that goes to only the index finger, and an extensor of the little finger that only goes to the pinky, and that will be on the medial or ulnar side of the extensor digitorum. There are 15 intrinsic muscles in our hand, meaning that these muscles begin and end within this region of our body. Now, rather than taking a look at all of these named individually, what we're going to do is consider them as a part of 4 different groups. The first group are known as the thenar muscles. These 3 muscles are going to affect movements of our thumb, and as you look at the names of those muscles, they will tell you a more accurate description of what action of what structure with a descriptor, similar to how the names in our forearm worked. So here, we see the abductor pollicis brevis, which tells us that this shorter muscle abducts the thumb. The three thenar muscles are located on the radial or lateral aspect of the hand. Their counterparts are the hypothenar muscles, which are located on the medial aspect or ulnar side of our hand, coming towards the little digit. Separating these two groups of muscles, the thenar and the hypothenar, we see the palmar aponeurosis. This thick, strong connective tissue is going to be connected to the tendon of the palmaris longus muscle. So recall that the palmaris longus muscle went superficial to the flexor retinaculum, and it's going to attach to this thick connective tissue in the palm of our hand, the palmar aponeurosis. If I hide the palmar aponeurosis, we can more clearly see the other two deep groups of muscles. The first of these are the lumbricals, and there are 4 lumbricals. The lumbricals mean worm-like, and these small muscles are going to attach on the radial side of the flexor digitorum profundus muscle tendons. So the lumbricals are going to cause action at our metacarpal phalangeal joints as well as the interphalangeal joints. The interossei are the muscles in between the bones of our hand. We're going to have 2 sets, a palmar set of interossei closer to the palmar surface and a dorsal set of interossei towards the dorsum of our hand. Now, in further courses, you may look at the names of these individually, but for now, just lump them into these 4 categories: thenar muscles, hypothenar muscles, lumbricals, and interossei. Hello, my name is Dr. Alan Detton, and in this lecture, I will be going over the muscles of the lower limb with my colleague, Dr. Erin Fillmore. Dr. Fillmore is going to introduce you to the muscles of the gluteal region, and by the end of her lecture, you will be able to identify the major muscles in the gluteal region and list the dominant actions and sources of motor innervation for this part of the lower limb. She will also introduce the muscles of the lower limb and the idea of the compartments within the thigh. I will then continue and list the dominant actions and sources of motor innervation for the muscles within each of these 3 compartments. I will then continue to explain how you can identify the muscles in each of the 3 compartments of the leg and list their dominant actions and sources of motor innervation. And lastly, end with identification of some of the key structures in the foot and comparing it to the organizational structure of the hand.
The lower limb is an incredibly interesting and organized part of the body. While your lower limb looks a fair bit different than your upper limb, and distally the lower limb ends in your foot, not a hand, there are an astounding amount of similarities between your upper and lower limbs, even with how the muscles are organized. However, while there are many similarities when comparing the lower limb to the upper limb in terms of bones, joints, and compartments, it is functionally quite different. First, the lower limb primarily functions to support the weight of the body, with a fairly minimal expenditure of energy to do so. Just think of how little energy it takes for you to stand still in one place. Our upper limbs are not designed for weight bearing, and we would tire very quickly if we had to maintain a handstand for a long period of time. Second, the lower limb functions to move our body through space, otherwise known as locomotion. While some people are talented enough to walk on their hands, most of us lack this talent. Now, it is crucial to understand that the way that the muscles of the lower limb are organized are optimized for these 2 purposes. The gluteal muscles posteriorly, the thigh muscles, leg muscles, and even foot muscles are all optimized to help us bear the weight of our body and to aid in locomotion. For example, muscles in the lower limb often have more bulk and act on joints with much less refined dexterity than the muscles in the upper limb. Functionally, this makes sense, especially when you consider doing something like shooting a basketball into the air, an act that requires that you use your lower limbs to jump high into the air, whilst during the same series of movements, your upper limbs will have the much more delicate task of shooting the basketball towards the narrow hoop you are trying to reach. So let us consider a general introduction to the muscles of the lower limb in the context of what we have just discussed. The lower limb is divided into 4 regions. First, the gluteal region, seen posteriorly. Second, the thigh region. Third, the leg region. And fourth, the foot. These divisions are based on major joints, bones, and surface anatomy landmarks. The gluteal region, if we move posteriorly, is both posterior and lateral, and between the iliac crest of the pelvis and the fold of skin called the gluteal fold that defines the lower limit of the buttocks. This region's muscles are powerful, and while specifics will be discussed shortly, muscles here are responsible for extending the thigh. This is the action you do when you stand up from sitting down in a chair. But they are also responsible for laterally rotating the thigh, abducting, and even medially rotating the thigh. The muscles in the gluteal region are hugely important for assisting in normal walking mechanics as well. They do this by ensuring that our pelvis remains relatively horizontal when one foot is off the ground and half of our pelvis is unsupported by the lower limb during the swing phase of our gait. Now, if we move more anteriorly, remember that the thigh is the region between the anterior structure called the inguinal ligament and the knee. And the posterior thigh is going to be between the gluteal fold and the knee. The thigh's musculature in this region can be divided into 3 compartments. A medial compartment that is largely responsible for adducting the thigh. Think of adduction as the action required to keep your thighs together as you sit tightly on a horse's saddle. Second, the anterior compartment, which is largely responsible for extending the knee and to a more minor extent flexing the hip. Extending the knee and flexing the hip. And thirdly, the posterior compartment, which contains muscles, seen here, that help to extend the hip and flex the knee. Finally, the leg is the region located between the knee and the ankle joint, and like the thigh contains 3 major compartments, each filled with muscle. But this time, instead of an anterior, posterior, and medial compartment as seen in the thigh, the leg contains an anterior, posterior, and lateral compartment, with the posterior compartment of the leg containing most of the muscle bulk and the muscle power. Now, even more distally, we can see the 4th and final region, the foot. Simply recognize now it's an area distal to the ankle joint and crucial for locomotion. The gluteal region is between the iliac crest of the pelvis and inferiorly the fold of skin called the gluteal fold that defines the lower limit of the buttocks. Now, one way in which to think about the gluteal region's musculature is in layers. The muscles can be thought of as being organized into a superficial layer of muscles and a deep layer of muscles, with the deep layer muscles being fully seen only when the superficial muscles are either removed or reflected away. Let us talk about 4 structures important in the superficial gluteal region. The gluteus maximus, the gluteus medius, which you see only the upper part of here, the iliotibial tract, or IT band, and the tensor fasciae lata. The gluteus maximus is a muscle that overlays the hamstring muscles. It is a thick, flat sheet of muscle and is actually the largest muscle in the gluteal region. Gluteus maximus is quadrangular in shape and arises from the back of the ilium, from the side of the sacrum, and from the deeper sacrotuberous ligament, all portions of the bony pelvis. Distally, the upper 3/4 of gluteus maximus inserts and blends into the tendinous thickening of the fascia lata, otherwise known as the iliotibial tract. The lower 1/4 of gluteus maximus passes much more deeply and inserts upon the back of the femur on the bony bump called the gluteal tuberosity, which is part of the proximal superior aspect of the femur. Gluteus maximus works principally to extend the flexed thigh at the hip. Think of this muscle working very hard to help you get up from sitting down in a chair. However, through its insertion into the iliotibial tract, or IT band, which we can see here, it also stabilizes both the hip and the knee joints. So how does it do this? Well, the tensor fascia lata is a small muscle, a muscle that acts on the knee when the knee is extended. The knee is in full extension when you are standing up straight. This little muscle acts on the knee joint to extend it by acting on the specialized iliotibial or IT band. The iliotibial tract is a longitudinal band of very tough, thick, deep fascia that extends all the way from the ilium of the pelvis, up here, down the lateral side of the thigh, and eventually attaches to the proximal end of the tibia in the leg. This band of tissue is very strong, and it must be, as proximally the fibers of gluteus maximus pull on it as it crosses and acts upon the hip joint, and distally it helps to stabilize the knee joint. Now if we look at gluteus medius, which in this view we see only its upper superior portion, it is a muscle that arises from the uppermost portion of the ilium of the pelvis and inserts upon a large bony proximal bump on the femur called the greater trochanter. This muscle, while deep to glute max, overlies glute minimus and is fan-shaped. Both gluteus medius and the deeper, smaller muscle just mentioned, gluteus minimus, help to abduct the lower limb at the hip. Both gluteus medius and minimus have another very important function. Because their muscle fibers are quite vertically aligned in how they stretch over the hip joint, when these fibers contract, they reduce pelvic drop over the opposite limb during the swing phase of walking. They do this by securing the position of the pelvis on the stance limb or the limb you have planted into the ground. Again, contraction of glute medius and minimus on the stance side, or the side of the body where the foot is planted on the ground when walking, pulls down on the ilium on that same side, and thus raises the opposite side of the pelvis up. This contraction is crucial in order to help keep the pelvis level each time we take a step, and makes it much easier for the opposite foot to move and swing forward through the air without touching or sagging towards the ground. When we consider the deeper areas of the gluteal region, we have to consider a number of very important muscles. In this view, we have removed gluteus maximus and medius and are now looking at a series of posterior, small, deep gluteal muscles. Gluteus minimus is one of the more superior deep muscles we see in the gluteal region. It is fan-shaped, just like the gluteus medius, and originates from the broad wing. As the muscle fibers descend, they converge inferiorly and laterally to form a tendon which inserts onto the greater trochanter of the femur. The same bony bump on the proximal femur where the gluteus medius inserts. This muscle abducts the femur. Now if we look just inferior to the gluteus minimus, we see another muscle. This muscle is called the piriformis muscle. In Latin, piriformis means pear-shaped, and we can see that this muscle is indeed shaped like a pear. The piriformis muscle stretches from the anterior lateral surface of the sacrum, here, and leaves the pelvis by passing through the greater sciatic notch. This notch creates a foramen when other ligaments, which are not in this picture, are in place. It's an opening that is found in the posterior pelvis. It exits this large foramen along with the sciatic nerve. The sciatic nerve is a very large nerve that supplies most of the lower limb. As the piriformis exits the pelvis across the hip joint posteriorly, it eventually inserts here, high up on the medial aspect of the greater trochanter, just a little bit below and posterior to where gluteus medius and minimus insert. The piriformis is a very important muscle to understand because not only does this muscle act as a powerful lateral rotator of the hip, it is closely related to the sciatic nerve, as both emerge from the pelvis in the same area, and as such, this muscle can sometimes entrap this nerve and cause pain to radiate down the lower limb. Now, if we look at a few of the other deep muscles in the gluteal region, you will notice a number of other short muscles inferior to the piriformis that also arise off the pelvis and insert around the same area on the greater trochanter of the femur. These are the superior and inferior gemellus muscles, with the obturator internus snuggled between the two, and the most inferior muscle of the set, the quadratus femoris. The obturator internus arises from a wide area on the ilium and ischium of the pelvis, and from the obturator membrane, seen here. It is a strong anchoring point, and this muscle leaves the pelvis through the lesser sciatic foramen, which is inferior to the greater sciatic foramen. Remember, the greater was where the piriformis exited the pelvis with the sciatic nerve. As the obturator internus passes around the back of the ischial spine of the pelvis, it makes a turn and is joined above and below by the superior and inferior gemellus muscles. Finally, the last of the short rotator muscles can be seen here, the quadratus femoris. It is four-sided and looks a bit quadrangular in its shape. Quadratus femoris arises from the ischial tuberosity medially and inserts on the femur there. A bony ridge inferior to the greater trochanter called the intertrochanteric crest. Now, all of these short rotator muscles, namely the piriformis, the superior and inferior gemellus, the obturator internus, and quadratus femoris, all pull back on the femur medially and produce lateral rotation of the hip. Remember, a muscle only pulls when it contracts. It doesn't push. So when a muscle contracts, its length shortens, meaning that the two bony areas that it is attached to get closer together. So when looking at these short muscles of the deep gluteal region, it makes sense that when these muscles shorten, they pull on their more distal bony attachment. And as the muscle belly shortens, these lateral rotators pull on either the greater trochanter or the intertrochanteric crest and brings those bony structures of the femur more medially, thus causing an overall hip rotation laterally. Before we move on to the individual muscles you can find in the thigh, it is important to think about the organization of this region of the body. If you remember from our introduction to the lower limb, the thigh is a region that is divided into three distinct compartments by layers of fascia, bone, and ligaments. Each of the major compartments in the thigh shares certain features. Generally, all the muscles found in one compartment have the same general action, they share the same general nerve supply, and even share the same general blood supply. Now, there are a few exceptions to these rules, but thinking about each compartment sharing similar actions and characteristics is a good way to start learning this region. The view we see here is a view of the thigh that we have made a transverse cut through. You are looking up into the thigh from below. Note the bony femur in the center. From this view, you can see three compartments. First, the medial compartment, sometimes called the adductor compartment because the actions of the muscles here produce adduction of the hip. Second, you can see the anterior compartment here, sometimes called the extensor compartment because the actions of the muscles here produce extension of the knee. And finally, you can also see the posterior compartment here, sometimes called the flexor compartment because the actions of the muscles here produce flexion of the knee. Now let's review the characteristics of the three individual compartments again. First, the medial compartment. Most muscles in the medial compartment act mainly on the hip joint to adduct it. Many of them actually have the word adductor in their name, reminding you of what they do. And nearly all of these muscles in this compartment are innervated by the obturator nerve. Second, we can see the large muscles in the posterior compartment. This is the hamstring group, composed of three separate muscle bodies. The hamstrings act on the hip to extend it and act on the knee to flex it. And they're able to do this because they attach to both the pelvis and the bones of the leg. The muscles in this compartment are innervated by the sciatic nerve. Finally, we can see the muscles in the anterior compartment here. This is the quadriceps group, composed of 4 separate muscle bodies. The quadriceps cross the knee to insert on the anterior tibia, so when the muscle belly shortens of this muscle group, it pulls on the tibia and extends the knee. This muscle also has a minor role in hip flexion. All muscles here in this compartment, except the tensor fascia lata, are innervated by the femoral nerve.
The muscles of the anterior compartment of the thigh can be subdivided into 2 groups: those that flex the hip, known as our hip flexors, and the 4 muscles that are grouped as the quadriceps. The quadriceps femoris is a 4-muscle bellied structure. These 4 muscles are readily identifiable if we begin with the first muscle that lies most anteriorly, the rectus femoris. The term rectus means straight, so this is the straight muscle of the thigh. As we can see here, the rectus femoris is going to cross both the hip and the knee. So it's going to produce action at both joints. It is going to help with flexion of the hip and with extension of the knee. So as we look at these different muscles, think about what joint they cross, as that will help you understand what movement it can produce. I've removed a piece of the rectus femoris to better visualize the 3 underlying muscles remaining within the quadriceps group. The first of which is located medially. This is a large muscle, hence its name vastus. The vastus medialis is the most medial of the 4 quadriceps muscles, and it's going to attach on the medial aspect of the patella to help straighten our kneecap during knee extension. The vastus lateralis is its counterpart on the opposite side of the thigh. Here we can see that the vastus lateralis passes immediately deep to the iliotibial tract, or the IT band, which will help you identify this large muscle on the lateral side of the thigh. Sandwiched between the laterally located vastus lateralis and the medially located vastus medialis, we see the vastus intermedius, which again you can now see because of the cut window through the rectus femoris. If I had not cut a piece out of the rectus femoris, we would not be able to visualize the underlying vastus intermedius. Now the 4 quadriceps muscles are going to share a common distal attachment. The 3 vastus muscles only cross the knee and do not cross the hip. Thus, they're only going to produce action at the knee. How they do this is as a group through their common attachment to the quadriceps tendon. The quadriceps tendon is going to attach along the superior aspect of the patella and then continue down towards our leg as the patellar tendon or ligament. Now, this has both names depending on if you talk to an anatomist or a surgeon. Technically, a tendon is going to attach between a muscle and the bone, while a ligament attaches from bone to bone. So this technically meets both qualifications. It's the continuation of the quadriceps muscles down to the tibia, but it's also the connection between the patella and the tibia. So it technically is both a tendon and a ligament, though they'll often refer to this as a patellar tendon reflex when they're testing the strength of the quadriceps. The second group of muscles in the anterior thigh is known as the hip flexors. So based on the name, you could probably guess the action. The dominant hip flexor is the combination of 2 muscles, the more medially located psoas major muscle and the more laterally located iliacus. As these 2 large muscles pass inferiorly, they go deep to the inguinal ligament. As they do so, the name is going to change to become iliopsoas. So what was once two muscles now becomes a single muscle to provide powerful hip flexion. Medial to the iliopsoas, I can see the small medially located pectineus muscle, which is also often categorized as a medial compartment of the thigh muscle because it shares dual innervation, meaning it gets a nerve from the anterior thigh and a nerve from the medial thigh to help it work. The last of the muscles in the thigh is going to produce both hip flexion and knee flexion, and this is the longest muscle in the lower limb, the sartorius muscle. If you were to cross your leg and put the right ankle on your left knee, that's the action of the sartorius. The muscles of the medial compartment of the thigh can be remembered with a useful mnemonic. Great Major League Baseball players. This is going to tell you the order from inferior to superior as we move up and in through the medial thigh. Before we start taking a look at the individual muscles, I want to simply review the action of hip adduction. This is the ability for us, with your legs spread, to pull the thigh back in towards anatomical position. So the muscles here in the medial compartment of the thigh are going to all share this common action of hip adduction, pulling our thigh from a more lateral position back in towards medial position or anatomical position. The first of the muscles that we're going to look at in this sequence is the longest of the group. And this is actually the most medial muscle of the thigh, the gracilis muscle. Now, an easy way to remember the name of this muscle is that there's really only two responses if somebody grabs your inner thigh. You can either say gracias or no gracias. So the gracilis is a long muscle that's going to cross both the hip and the knee. Therefore, it produces adduction of the hip and it's going to produce flexion of the knee. Now, as we start to move up from the great for gracilis, the next muscle we're going to encounter is the adductor magnus. The adductor magnus is a large, powerful muscle of the thigh that takes up a lot of space, and is positioned just lateral to the gracilis. As I rotate the thigh around, we can see that the adductor magnus continues superiorly and posteriorly, and it actually has two large portions, a more medially located adductor portion and a more posteriorly located hamstring portion. So this big muscle is going to assist in both adducting my thigh and extending my thigh. As I move more superiorly, the next muscle that I'm going to encounter is the adductor longus. And I've cut it to remove a piece of the adductor longus so that you can see the underlying muscles more clearly. Now, what we're starting to see is that the medial thigh has layers to it. There's going to be two muscles that are more deeply located, the adductor magnus, which is right next to the next adductor, the adductor brevis. So the adductor brevis is more laterally located, the adductor magnus is more medially located. But these two muscles both are positioned deep to or posterior to the overlying adductor longus. So it's pretty important to understand this concept that we go from deep to superficial back to deep in the sequence of great Major League Baseball players. The players is for the last medial compartment muscle, pectineus, which is also going to be part of our anterior thigh because it helps with hip flexion. This small muscle is going to be innervated by the nerves that supply both compartments. In the medial compartment of the thigh, we can see the obturator nerve, which is going to pass from the pelvic cavity into this medial group of muscles. So, if I were to lose the obturator nerve, I would lose the ability to adduct my thigh. So remember, as you look at the medial compartment of the thigh, the simple mnemonic for great Major League Baseball players to remember gracilis, adductor magnus, adductor longus, adductor brevis, and ending with pectineus. The muscles of the posterior thigh are dominated by a group of 3 muscles, which are known as the hamstrings. So if you've ever seen a runner pull up short after starting with a sudden burst and grab the back of their thigh, they've likely torn or strained the hamstring muscles. They pulled a hammy. The hamstring muscles are going to consist of 3 long muscles that are going to cross both the hip and the knee. Thus, they're going to produce action at both of these joints. Let's begin by taking a look at the medial aspect of these muscles, beginning with the large semimembranosus muscle. Now, this muscle gets its name because of its semi or half membrane-like appearance. And if I were to fade the overlying muscle, we could see that this is going to have a broad, flat appearance in cadaveric specimens. Now, the semimembranosus is going to be a muscle crossing both the hip and the knee, and it's going to share a similar function with the overlying semitendinosus, which gets its name because of its half tendon-like appearance. Now, the semitendinosus inferiorly is going to have a much thinner, narrower, and cord-like band of a tendon, which is where it gets its name of half tendon-like. So the semitendinosus and the semimembranosus are both going to pass medially at the knee. These muscles are going to help extend my hip and flex my knee, which is the same action as the last of the 3 hamstring muscles, the long head of the biceps femoris. What I can see here is that the long head crosses the hip, but it's going to pass laterally at the knee. As its name indicates, the biceps femoris is going to have 2 heads. So the long head of the biceps femoris is a hamstring muscle, but the other head, the short head of the biceps femoris, does not cross the hip. It only crosses the knee. So this muscle is not a hamstring, even though it's only half of the biceps femoris. So the short head of the biceps femoris is going to help with knee flexion, while the 3 hamstring muscles, the long head of the biceps femoris, the semitendinosus, and the most medially located semimembranosus, both cross the hip and the knee. The point of attachment for the 3 hamstring muscles is a roughened part of the ischium known as the ischial tuberosity. So if you've ever sat on somebody's lap and they complained that you had a bony butt, this is what they're feeling, is the ischial tuberosity pressing down on their thigh. The hamstrings, again remember, are going to cross both joints, produce hip extension and knee flexion, while the short head of the biceps only crosses the knee and thus only flexes the knee. Similar to the organizational structure of the thigh, which consisted of 3 different compartments, each of which shared commonalities with common innervation, common actions, blood supplies, etc., the muscles within the leg are going to be formed into 3 different compartments that are going to be subdivided by the deep investing fascia and surrounded by the overlying skin. Within this region of the lower limb, between the knee and the ankle, we're going to have the leg. And the difference between what we saw with the cross-sectional cut of the thigh and what we see here is that there's the presence of now 2 bones, which helps me know that I'm within this region. If I were looking at the thigh, I would have only seen a centrally located femur. When I look at the cross-section of the leg, I can see a more superficially and medially located tibia and a more deeply and laterally located and smaller fibula. These 2 bones are going to be connected by a piece of connective tissue known as the interosseous membrane. This is a connection, as its name implies, between the bones. Bone being os, inter, between. So interosseous is going to form a tough connection and a joint between the medially located tibia and the laterally located fibula. This concept of where the bones are positioned and the interosseous membrane is going to help you identify the organizational structure here within the leg. If I am positioned anterior to the interosseous membrane, I find myself in the first of the three compartments, the anterior compartment of the leg, which is going to have 4 muscles. If I go lateral to the fibula, I'm going to find myself in the lateral compartment of the leg, which has 2 muscles. Posterior to the interosseous membrane and the 2 bones within the leg, I'm going to find myself within the posterior compartment, which has 2 groups, a more superficially located group and a more deeply located group. As we look at the muscles and organizational structure of the leg in more detail, it's important to understand this concept that you're going to have common actions produced by a common nerve supplying that group of muscles. So as an overview, we're going to see that there are 3 different nerves, one each supplying each of these 3 different compartments. Within the anterior compartment, we're going to see the deep fibular nerve. In the lateral compartment, the superficial fibular nerve. And within the posterior compartment, the tibial nerve. There's also going to be commonalities with blood supply in each of these compartments, as well as actions. Recall that the leg is the portion of our lower limb located between our knee and our ankle. So if I'm referring to the anterior muscles of the leg, it's within this region below my knee and not somewhere else up in my thigh. This group of muscles is going to perform a common action as a group, which is going to be to elevate the top of my foot in an action known as dorsiflexion. Now, flexion is typically reducing the angle between 2 different regions. In this case, I can elevate the top of my foot and reduce the distance between that surface and the anterior aspect of my leg. So these group of muscles in the anterior compartment of the leg are all going to assist in this action of elevating the top of my foot, known as dorsiflexion. To begin, let's look at a couple of key landmarks. I like to look first for the medially located tibia, and you can see that there's going to be a sharp ridge known as the anterior tibial crest extending down the front of your shin. Now, these muscles are all located on the lateral side of that ridge. They're going to pass down into the top of my foot, but stay in their relationship to the tibia and be in front of it. As they cross the ankle, all of these tendons are going to be positioned between the medial malleolus, the large bony prominence on the medial aspect of my ankle from the tibia, and the more laterally located lateral malleolus, which is going to be the large bony prominence on the lateral side of my ankle, but comes from the fibula. So these 4 muscles are going to be positioned between the 2 bumps, the medial malleolus and the lateral malleolus. Beginning with identification of the tibia will help you identify the first of these 4 muscles, which is named for its relative location to that bone, the tibialis anterior. This long muscle is going to come down and insert on the medial side of my foot. So it's not only going to assist with elevating the top of my foot in an action known as dorsiflexion, but it also helps pull up the inner aspect of my foot in an action known as inversion. If I were to move lateral from the tibialis anterior, The next muscle I would encounter is going to have a tendon that attaches to the great toe or the big toe, known as the hallux. This muscle helps me lift up my big toe. It's known as the extensor hallucis longus. So it's going to not only help me dorsiflex the whole foot, but it's individually going to help you raise your big toe off the floor, extending it. If I continue to move laterally, I'm going to encounter a large muscle that's going to send tendons to the other 4 toes, or my digits. This muscle is the extensor digitorum longus, and it's going to have 4 attachments to help you raise each of the other 4 toes off of the ground. So it's going to again help with dorsiflexion, but also with extension of the other toes. The last muscle is a small muscle that means the third, the fibularis tertius. What we're going to see is that there's 2 muscles in the lateral compartment of the thigh that relate to this small muscle in relation to the fibula. It's going to attach on the lateral aspect of my foot and help me with eversion, or lifting the side of my foot, as well as dorsiflexion. The lateral compartment of the leg is perhaps the easiest to understand, as it only has 2 muscles. These 2 muscles are going to extend posterior to the bony landmark of the lateral malleolus. So they're going to pass between a gap between the lateral malleolus of the fibula and the calcaneus, where we can see the large calcaneal tendon attaching. These 2 muscles are going to both be named due to their relationship with that bone. Let's first take a look at the more superficial overlying muscle, the fibularis longus. The fibularis longus is going to overlie the underlying fibularis brevis. So the one that is closer to the fibula is the brevis, while the one that is slightly further away from it is the fibularis longus. Now, as these 2 muscles pass posterior to the lateral malleolus and reach their attachments in the base of the foot, we can see the reason why they get their names. The fibularis brevis is going to terminate or end sooner, while the fibularis longus has a much longer tendon that's going to continue all the way to the medial side of the foot. So what we're going to see is that these 2 muscles attach to both the lateral and medial sides of the foot, with the fibularis brevis attaching at the base of the 5th metatarsal and the fibularis longus continuing across my foot to the base of the 1st metatarsal. When these 2 muscles combine to flex, what's going to happen is they're going to pull the bottom of the foot down and assist with plantar flexion, but they're also going to pull up the side of the foot in an action known as eversion. This is going to elevate the lateral aspect of my foot, and these muscles are assisted by a muscle from the anterior compartment, the fibularis tertius. So we end up having 3 fibular muscles, the longus, the brevis, and the tertius, all of which assist in elevating the lateral side of the foot. Now, the 2 muscles in the lateral compartment are also going to assist in pulling the bottom of my foot down, as I mentioned, in the action of plantar flexion. Now, they only really assist this action as the dominant plantar flexors are found in the posterior compartment. To produce these actions, the 2 muscles, the fibularis longus and fibularis brevis, share a common innervation. This is going to be from a nerve that splits off of the common fibular nerve. Now, the common means it's going to split. So common fibular is going to split into 2 components, a more laterally located superficial fibular nerve and a more anterior located deep fibular nerve. These 2 branches of the common fibular nerve are going to supply the anterior and lateral compartments of the leg. The superficial fibular nerve is going to supply this lateral compartment, while the deep fibular nerve innervated the anterior compartment. So compression or injury at the back of the knee, damaging the common fibular nerve, could produce damaging results in both the lateral and anterior compartments of the leg. The posterior compartment of the leg can be subdivided into two different groups, a superficial group and a deep group. We'll begin by taking a closer look first at the superficial group of muscles and the structures in this area. To begin, let's look posteriorly at our heel, where we can identify the calcaneus, the prominent bone in the back of our foot. Attaching to the calcaneus, we can see the calcaneal tendon, a large, strong attachment for the superficial compartment muscles. As a result, these muscles are all going to share a common point of attachment, which means that they're going to share a common action at the ankle. The most superficial and posteriorly located of these muscles is a muscle known as the gastrocnemius. This muscle has two portions, a medial head and a lateral head. As we can see, the muscle is going to cross the knee joint as well. So it's not only going to join with its attachment at the calcaneal tendon to produce action at the ankle, but it's going to produce action at the knee. To help you remember the action of the gastrocnemius, I want you to think of this as the scooching muscle. If you've ever been sitting down in a chair and you need to scooch forward or pull your chair forward, you're going to feel your calf, this posterior muscle, tighten up. So the gastrocnemius is going to cross the knee and assist in knee flexion. It's also going to help stabilize your knee when you are plantar flexed. Really closely associated to the gastrocnemius, and in fact to visualize it, I've needed to cut one of the heads of the gastrocnemius, I can see the underlying plantaris muscle. I like to think of this muscle as helping you plant your foot. So the plantaris muscle is going to have a really long, thin tendon that is also going to attach to the calcaneus. So this small muscle is going to help with plantar flexion, and it's located right behind or posterior to my knee on the lateral aspect. Positioned deep to the gastrocnemius on both the medial and the lateral side of my leg is the large soleus muscle. Now, in order to better see the soleus muscle, I'm going to hide the overlying gastrocnemius muscle so you can see the size and expanse of this large muscle. The soleus got its name because it looked like a filleted fish, the sole fish. And the soleus is going to share a large attachment with the calcaneus to the calcaneal tendon and the calcaneal heel bone. Now, when these muscles contract, it's going to produce plantar flexion. So the soleus is only going to produce plantar flexion because it does not cross the knee. So you can see that it is assisted by the gastrocnemius. Now, the gastrocnemius tends to get all the credit because it's more superficial and more identifiable, but the dominant plantar flexor at our ankle is actually the soleus muscle because this large, powerful muscle can only produce plantar flexion, while the gastrocnemius was also concerned with scooching or flexing our knee and stabilizing the knee when we are in a fully plantar flexed position or in tiptoe. The posterior compartment of the leg had two different portions. The superficial compartment, which consisted of the gastrocnemius with its medial and lateral heads, the plantaris, and the soleus. Let's now take a closer look at the deep group of muscles within this posterior compartment by hiding and fading the superficial group. So here we can see the faded soleus, which would cover up and overlay all of these muscles within the posterior compartment of the leg in the deep group. Again, for orientation, it helps to begin with identification of the calcaneal tendon, attaching to the calcaneus, the posterior aspect of our heel. It also helps for orientation to identify the medial malleolus, the inferior distal continuation of the tibia. We can see that the tendons within this deep compartment are going to pass between the medial malleolus and the calcaneus. So we're going to see the three different tendons extending from the deep compartment of the leg into the sole of our foot, again between the medial malleolus and the calcaneus. The first of these is going to be positioned as close to the tibia as we can when we pass behind the ankle. This is the tibialis posterior. The tibialis posterior is going to attach on the medial aspect of the foot to produce the action of plantar flexion. Really close to the tibialis posterior, and in fact overlying the majority of its muscle belly, we can see the flexor digitorum longus. Now, as its name implies, it is going to flex the digits, or our toes, and have a long tendon. As we pass posterior to the medial malleolus and cross into the foot, we can see the tendon of this muscle branching and splitting to the four lateral toes, or digits. So the flexor digitorum longus is not only going to assist in plantar flexion, but it's also going to assist in flexing of our actual toes, or curling them down towards the plantar surface of our foot. If we were to go lateral to where we saw the tibialis posterior and the flexor digitorum longus, we see the last of the muscles within the deep compartment of the leg, the flexor hallucis longus. The flexor hallucis longus is positioned deep to the calcaneal tendon, and it is often difficult to see in dissection due to this deep location where it passes posterior to the ankle joint. As its name implies, the flexor hallucis longus is going to flex our hallux, or the big toe, and has a long tendon. So as we look at the sole of the foot and we identify the tendon of this muscle, we can see that it's going to continue all the way down towards the distal end of my big toe. Again, as it's going to contract or produce movement, it will assist in flexion of the great toe. So the flexor digitorum longus is going to flex my four digits, while the flexor hallucis longus is going to focus on flexing of the big toe. As a group, these deep compartment muscles are going to assist in the action of plantar flexion with the superficial group. All of these muscles in the posterior compartment of the leg are going to share a common innervation by the tibial nerve. So we're going to see that behind the knee, this nerve, the tibial nerve, is going to descend into the posterior compartment of the leg, where it's now going to be able to provide motor innervation to both the superficial group of muscles and the deep group of muscles. The foot is the inferiormost aspect of our lower limb, and it's specially designed to assist in walking around and supporting the weight of our body. So although it bears some semblance to the hand in that it can have an action of both flexion and extension of the digits, it's going to have some very specific adaptations and unique differences as compared to the hand. One thing I do want to highlight is that we see here a faded portion of the extensor retinaculum. Note how this fibrous piece of connective tissue helps hold down the different tendons passing into the foot. This concept is quite important as it's going to allow for more efficient contraction of muscles positioned higher up in the leg. So as the muscles within the leg contract, it's going to produce motion in the foot around the ankle joint. And how this is done is by holding down the tendons tight up against the bones by these retinacula. If I didn't have the retinacula and the muscle were to contract, all that would happen would be the muscle would bow out directly from its point of origin to its point of insertion. So these are going to act like a pulley to hold down the tendons and allow for more efficient motion within the foot. Now, a difference between the hand and the foot is that we're also going to have muscles within the dorsum of the foot, where we did not see that in the hand. On the dorsal aspect of the foot, I do have small muscles that will elicit direct action. The more medially located of the two is going to go directly to the big toe, but it has a shorter length than its longer counterpart that extends from the anterior leg. This is the extensor hallucis brevis muscle. On the lateral aspect of the foot, I'm also going to see the muscle belly of the extensor digitorum brevis muscle, which is going to send 4 tendons to the other 4 digits. These 2 small muscles are going to assist in the stronger, larger actions from the muscles in the anterior leg, the extensor hallucis longus and the extensor digitorum longus. So that is a key difference between the foot and the hand, in that I do have small muscles within the dorsum of the foot. Now on the plantar surface, or the sole of the foot, we're going to only look at the first layer of muscles within this region. The foot is quite complex and has 4 different layers of tissue. The first actual layer is made up of a tough, fibrous piece of connective tissue known as the plantar aponeurosis. So if you've ever heard of somebody getting plantar fascia, or fasciitis, I should say, it's due to inflammation of this tough piece of tissue. Now, deep to the plantar aponeurosis, which has been cut, we can see the underlying flexor digitorum brevis, which is going to extend from the calcaneus posteriorly to each of the toes anteriorly. This small muscle is going to reside in the first layer of the sole of the foot and assist in curling our toes with the flexor digitorum longus. Now, to either side of the flexor digitorum brevis, we're going to see 2 muscles that help pull my toes out away from the midline. There's going to be, on the medial side of the foot, an AB, or abductor hallucis, and on the lateral side of my foot, an AB, or abductor digiti minimi. So I'm going to have a small muscle that helps pull my little toe out to help stabilize my foot when walking, and a small muscle that is going to help pull my big toe out while walking to again help stabilize the foot. So with a broader surface area, we're going to be able to have more balance and better ability to walk and move around.